bringing us to Chapter 4, Pharmacokinetics, Pharmacodynamics, and Drug Interactions. Pharmacokinetics. Pharmacokinetics is the study of drug movement throughout the body. There are four basic pharmacokinetic processes: absorption, distribution, metabolism, and excretion. Absorption is defined as the movement of a drug from its site of administration into the blood. Distribution is defined as drug movement from the blood to the interstitial space of tissue, and from there into cells. Metabolism, or biotransformation, is defined as enzymatically mediated alteration of drug structure. Excretion is the movement of the drugs and their metabolites out of the body. The combination of metabolism and excretion is called elimination. The four pharmacokinetic processes acting in concert determine the concentration of a drug at its site of action. So here you're taking a look at a picture of absorption, distribution, metabolism, and its excretion, and whether it's being metabolized in the liver, kidney, the site of action, or other sites, and its excretion via bile or urine. So the application of pharmacokinetics in pharmacotherapeutics. By applying knowledge of pharmacokinetics to drug therapy, we can help maximize beneficial effects and minimize harm. Recall that the intensity of the response to a drug is directly related to the concentration of the drug at its site of action. To maximize beneficial effects, a drug must achieve concentrations that are high enough to elicit desired responses. To minimize harm, we must avoid concentrations that are too high. This balance is achieved by selecting the most appropriate route, dosage, and dosing schedule. The passage of drugs across membranes. All four phases of pharmacokinetics, the absorption, distribution, metabolism, and excretion, involve drug movement. To move throughout the body, drugs must cross membranes. Drugs must cross membranes to enter the blood from their site of administration. When in the blood, drugs must cross membranes to leave the vascular system and reach their site of action. In addition, drugs must cross membranes to undergo metabolism and excretion. Accordingly, the factor that determines the passage of drugs across biologic membranes have a profound influence on all aspects of pharmacokinetics. Biologic membranes are composed of layers of individual cells. These cells, composing most membranes, are very close to one another, so close in fact that drugs must usually pass through cells rather than between them to cross the membrane. Hence, the ability of a drug to cross a biologic membrane is determined primarily by its ability to pass through a single cell. Three ways to cross a cell membrane. The three most important ways for drugs to cross cell membranes include the passage through channels or pores, passage with the aid of a transport system, and finally the direct penetration of the membrane. Of the three, direct penetration of the membrane is the most common. However, channels and pores. Very few drugs cross membranes through channels or pores. The channel and membranes are extremely small and are specific for certain molecules. Consequently, only the smallest of compounds, such as potassium and sodium, can pass through these channels, and then only if the channel is the correct one. Transport systems. Transport systems are carriers that can move drugs from one side of the cell membrane to the other side. All transport systems are selective. Whether a transporter will carry a particular drug depends on the drug's structure. Transport systems are an important means of drug transit. For example, certain orally administered drugs could not be absorbed unless they were transport systems to move them across the membranes that separate the lumen of the intestine from the blood. A number of drugs could not reach intercellular sites of action without a transport system to move them across the cell membrane. One transporter, known as the P-glycoprotein or multi-drug transporter protein, deserves special mention. PGP, again that P-glycoprotein, is a transmembrane protein that transports a wide variety of drugs out of cells. The direct penetration of the membrane. For most drugs, movement through the body is dependent on the ability to penetrate membranes directly, because most drugs are too large to pass through channels or pores, and most drugs lack transport systems to help them cross all the membranes that separate them from their site of action, metabolism, and excretion. A general rule in chemistry states that like dissolves like. Membranes are composed primarily of lipids. Therefore, a directly penetrant membrane, the drug must be lipid soluble or lipophilic. Certain kinds of molecules are not lipid soluble and therefore cannot penetrate membranes. This group consists of polar molecules and ions. Polar molecules. Polar molecules are molecules that have no net charge. However, they have an uneven distribution of electrical charge. That is, positive and negative charges within a molecule tend to congregate separately from one another. Water is a classic example, as depicted in Figure 4.1. As depicted in Figure 4.1, electrons in the water molecule spend more time in the vicinity of the oxygen atom than in the vicinity of the two hydrogen atoms. As a result, the area around the oxygen atom tends to be negatively charged, whereas the area around the hydrogen atom tends to be positively charged. In accord with the like dissolves like rule, polar molecules will dissolve in polar solvents, but not in nonpolar solvents. Ions. Ions are defined as molecules that have a net electrical charge. Except for very small molecules, ions are unable to cross membranes. Therefore, they must become non-ionized in order to cross from one side to the other. Many drugs are either weak organic acids or weak organic bases, which can exist in charged and uncharged forms. Whether a weak acid or base carries an electrical charge is determined by the pH of the surrounding medium. Acids tend to ionize in basic media, whereas bases tend to ionize in acidic media. Therefore, drugs that are weak acids are best absorbed in an acidic environment, such as gastric acid, because they remain in a non-ionized form. When aspirin molecules pass from the stomach into the intestine, where the environment is relatively alkaline, more of the molecules change to their ionized form. As a result, absorption of aspirin from the intestine is impeded. Ion trapping, the pH partitioning. Because the ionization of drugs is pH dependent, when the pH of the fluid on one side of the membrane differs from the pH of the fluid of the other side, drug molecules tend to accumulate on the side where the pH most favors their ionization. Accordingly, because acidic drugs tend to ionize in basic media, and because basic drugs tend to ionize in acidic media, when there is a pH gradient between the two sides of the membrane, the following occurs. Acidic drugs accumulate on the alkaline side, and basic drugs accumulate on the acidic side. The process whereby a drug accumulates on the side of the membrane where the pH most favors its ionization is referred to as ion trapping or pH partitioning. Absorption. Absorption is defined as the movement of a drug from its site of administration into the systemic circulation. The rate of absorption determines how soon effect will begin. The amount of absorption helps determine how intense effects will be. Two other terms associated with absorption are chemical equivalence and bioavailability. Drug preparations are considered chemically equivalent if they contain the same amount of identical chemical compound. Preparations are considered equal in bioavailability if the drug they contain is absorbed at the same rate and to the same extent. It is possible for two formulations of the same drug to be chemically equivalent while differing in bioavailability. The concept of bioavailability is discussed in Chapter 6. Factors affecting drug absorption. The rate at which a drug undergoes absorption is influenced by the physical and chemical properties of the drug and by physiologic and anatomic factors at the absorption site. The rate of dissolution. Before a drug can be absorbed, it must be dissolved. Hence, the rate of dissolution helps determine the rate of absorption. Drugs and formulations that allow rapid dissolution have a faster onset than drugs formulated for slow dissolution. The surface area. The surface area available for absorption is a major determinant of the rate of absorption. When the surface area is larger, absorption is faster. For this reason, absorption of orally administered drugs is usually greater from the small intestine rather than from the stomach. Recall that the small intestine, because of its lining of microvilli, has an extremely large surface area, whereas the surface of the stomach is relatively small. Blood flow. Drugs are absorbed most rapidly from sites where blood flow is high because blood containing a newly absorbed drug will be replaced rapidly by drug-free blood, thereby maintaining a large gradient between the concentration of drugs outside the blood and the concentration of drugs in the blood. The greater the concentration gradient, the more rapid absorption will be. The lipid solubility. As a rule, highly lipid soluble drugs are absorbed more rapidly than drugs whose lipid solubility is low. This occurs because lipid soluble drugs can't readily cross the membranes that separate from the blood, whereas drugs with a low lipid solubility cannot. The pH partitioning. pH partitioning can influence drug absorption. Absorption will be enhanced when the difference between the pH of the plasma and the pH at the site of administration is such that drug molecules will have a greater tendency to be ionized in the plasma. Characteristics of common used routes of administration. For each of the major routes of administration, whether oral, RPO, intravenous, IV, intramuscular, IM, and subcutaneous, subQ, the pattern of drug absorption, the rate and extent of absorption is unique. What's missing here is sublingual. Consequently, the route by which a drug is administered significantly affects both the onset and the intensity of effect. The distinguishing characteristics of four major routes are summarized here on this table. 4.1. Additional routes of administration, topical, transdermal, inhaled, each have unique characteristics that are addressed throughout the book as we discuss specific drugs that employ them. So, again, here's table 4.1 and the properties of major routes of drug administration. A good spot to hit pause so you can review. Distribution. Distribution is defined as the movement of drugs from the systemic circulation to the site of drug action. Drug distribution is determined by three major factors: blood flow to tissues, the available or ability of the drug to exit the vascular system, and, to a lesser extent, the ability of a drug to enter cells. Blood flow to tissues. In the first phase of distribution, drugs are carried by the blood to the tissues and organs of the body. The rate at which drugs are delivered to a particular tissue is determined by blood flow to that tissue. Because most tissues are well perfused, regional blood flow is rarely a limiting factor in drug distribution. There are two pathologic conditions, abscesses and tumors, in which low regional blood flow can affect drug therapy. An abscess has no internal blood vessel. Therefore, because abscesses lack a blood supply, antibiotics cannot reach the bacteria within. Accordingly, if drug therapy is to be effective, the abscess must usually be surgically drained. Solid tumors have a limited blood supply. Although blood flow to the outer region of the tumor is relatively high, blood flow becomes progressively lower towards the core. As a result, it may not be possible to achieve high drug levels deep inside tumors. Limited blood flow is a major reason that solid tumors are resistant to drug therapy. Exiting the vascular system. After a drug has been delivered to an organ or tissue by blood circulation, the next step is to exit the vasculature. Because most drugs do not produce their effect within the blood, the ability to leave the vascular system is an important determining factor of the drug's action. Drugs in the vascular system leave the blood at capillary beds. Typical capillary beds. Most capillary beds offer no resistance to the departure of drugs because, in most tissue, drugs can leave the vasculature simply by passing through pores in the capillary wall. Because drugs pass between capillary cells rather than through them, movement into the interstitial space is not impeded. The exit of drugs from a typical capillary bed is depicted here in the following picture. A good spot to hit pause if you need to review the anatomy. But that brings us to the blood-brain barrier, or BBB, which refers to the unique anatomy of capillaries in the central nervous system. As shown here in the following figure, there are tight junctions between the cells that compose the wall of most capillaries in the CNS. These junctions are so tight that they prevent drug passage. Consequently, to leave the blood and reach sites of action within the brain, a drug must be able to pass through cells of the capillary wall. Only drugs that are lipid soluble have a transport system that can cross the blood-brain barrier to a significant degree. So again, here is that picture of the blood-brain barrier. Another good spot to review if you need that refresher from anatomy. Recent evidence indicates that in addition to tight junctions, the blood-brain barrier has another protective component, the PGP. As noted earlier, PGP is a transporter that pumps a variety of drugs out of cells. In capillaries of the CNS, PGP pumps drugs back into the blood and thereby limits the access to the brain. The blood-brain barrier is not fully developed at birth. As a result, newborns have the heightened sensitivity to medicines that act on the brain. Likewise, neonates are especially vulnerable to CNS toxicity. Which brings us to the placental drug transfer. The membranes of the placenta separate the maternal circulation from the fetal circulation. However, the membrane of the placenta does not constitute an absolute barrier to the passage of drugs. The same factors that determine the movement of drugs across other membranes determine the movement of drugs across the placenta. Accordingly, lipid-soluble, non-ionized compounds readily pass from the maternal bloodstream into the blood of the fetus. In contrast, compounds that are ionized, highly polar, or protein-bound are largely excluded, as are drugs that are substrates for the PGP transporter that can pump a variety of drugs out of the placental cells into the maternal blood. So here is a picture of the placental drug transfer. Again, a good spot to pause if you need a review of the anatomy. Protein binding. Drugs can form reversible bonds with various proteins in the body. Of all the proteins with which drugs can bind, plasma albumin is the most important. Like other proteins, albumin is a large molecule. Because of its size, albumin is too large to leave the bloodstream. The following figure, 4.5, depicts the binding of drug molecules to albumin. Note that the drug molecules are much smaller than albumin, as indicated by the two-way arrows binding between albumin and drugs is reversible. Hence, drugs may be bound or unbound. So here you're taking a look at the albumin and the free drug. Even though a drug can bind albumin, only small molecules will be bound at any moment. The percentage of drug molecules that are bound is determined by the strength of the attraction between albumin and the drug. For example, the attraction between albumin and the anticoagulant warfarin is strong, causing nearly 99% of all warfarin molecules in plasma to be bound, leaving only 1% free. On the other hand, the attraction between the antibiotic gentamicin and albumin is relatively weak. Less than 10% of gentamicin molecules in plasma are bound, leaving more than 90% free. An important consequence of protein binding is restriction of drug distribution. Because albumin is too large to leave the bloodstream, drug molecules that are bound to albumin cannot leave either. As a result, bound molecules cannot reach their site of action or undergo metabolism or excretion during the drug-protein bond, or until the drug-protein bond is broken, so that the drug is free to leave the circulation. In addition to restricting drug distribution, protein binding can be a source of drug interactions, as suggested in the following figure 4.5a. Each molecule of albumin has only a few sites to which drug molecules can bind. Because the number of binding sites is limited, drugs with the ability to bind albumin will compete with one another for those sites. As a result, one drug can displace another from albumin, causing the free concentration of the displaced drug to rise, thus increasing the intensity of drug response. If plasma drug levels rise sufficiently, toxicity can result. So, entering cells. Many drugs produce their effects by binding with receptors located on the external surface of the cell membrane. However, some drugs must enter cells to reach their site of action, and practically all drugs must enter cells to undergo metabolism and excretion. The factor that determine the ability of a drug to cross cell membranes are the same factors that determine the passage of drugs across other membranes, namely lipid solubility, the presence of transport systems, or both. So, metabolism. Drug metabolism, also known as the biotransformation, is defined as the enzymatic alteration of drug structure. Most drug metabolism take place in the liver. Hepatic drug metabolizing enzymes. Most drug metabolism that take place in the liver is performed by the hepatic microsomal enzyme system, also known as the P450 system. The term P450 refers to the cytochrome P450, a key component of this enzyme system. It is important to appreciate that cytochrome P450 is not a singular molecular entity, but rather than a group of 12 closely related enzyme families. Three of the cytochrome P450 or CYP families, designated CYP1, 2, and 3 respectively, all metabolize drugs. The other nine families metabolize endogenous compounds, so your steroids, your fatty acids. Each of the three P450 families that metabolize drugs is composed of multiple forms, each of which metabolizes only certain drugs. To identify the individual form of cytochrome P450, designations such as CYP1A2, CYP2D6, and CYP3A4 are used to indicate specific members of the CYP1, 2, and 3 families, respectively. So, therapeutic consequences of drug metabolism. Drug metabolism has six possible consequences of therapeutic significance: the accelerated renal excretion of drugs, drug inactivation, increased therapeutic action, activation of prodrugs, increased toxicity, or decreased toxicity. So, accelerated renal drug excretion. The most important consequence of drug metabolism is promotion of renal drug excretion. The kidneys, which are the major organs of drug excretion, are unable to excrete drugs that are highly lipid soluble. Hence, by converting lipid soluble drugs into a more hydrophilic or water soluble form, metabolic conversion can accelerate renal excretion of many agents. Drug inactivation. The metabolism can convert pharmacologically active compounds to inactive forms. This is the most common end result of drug metabolism. The increased therapeutic action. Metabolism can increase the effectiveness of some drugs. For example, metabolism converts codeine into morphine. The analgesic activity of morphine is so much greater than that of codeine that formation of morphine may account for virtually all pain relief that occurs after codeine administration. The activation of prodrugs. A prodrug is a compound that is pharmacologically inactive as administered and then undergoes conversion to its active form through metabolism. Prodrugs have several advantages. For example, a drug that cannot cross the blood-brain barrier may be able to do so as a lipid-soluble prodrug that is converted to the active form in the CNS. Increased or decreased toxicity. By converting drugs into the inactive forms, metabolism can decrease toxicity. Conversely, metabolism can increase the potential for harm by converting relatively safe compounds into forms that are toxic. Increased toxicity is illustrated by the conversion of acetaminophen into a hepatotoxic metabolite. It is this product of metabolism and not acetaminophen itself that causes injury when acetaminophen is taken in overdose. A special consideration in drug metabolism. Several factors can influence the rate at which drugs are metabolized. These must be accounted for in drug therapy. The first is age. A drug metabolized capacity of infants is limited. The liver does not develop its full capacity to metabolize drugs until about 1 year after birth. During this time, before hepatic maturation, infants are especially sensitive to drugs, and care must be taken to avoid injury. Similarly, the ability of older adults to metabolize drugs is commonly decreased. Drug dosages may need to be reduced to prevent drug toxicity. The induction and inhibition of drug metabolizing enzymes. Drugs may be P450 substrates, P450 enzyme inducers, and P450 enzyme inhibitors. Drugs that are metabolized by the P450 hepatic enzymes are substrates. Drugs that increase the rate of drug metabolism are inducers. Drugs that decrease the rate of drug metabolism are called inhibitors. Often a drug may have more than one property. For example, a drug may be both a substrate and an inducer. Inducers act on the liver to stimulate enzyme synthesis. This process is known as induction. By increasing the rate of drug metabolism, the drug of active drug is decreased, and the plasma drug level falls. If dosage adjustments are not made to accommodate for this drug, a drug may not achieve therapeutic levels. Inhibitors act on the liver through the process known as inhibition. By slowing the rate of metabolism, inhibition can cause an increase in active drug accumulation. This can lead to an increase in adverse effects and toxicity. The first pass effect. The term first pass effect refers to the rapid hepatic inactivation of certain oral drugs. When drugs are absorbed from the gastrointestinal tract, they are carried directly to the liver through the hepatic portal vein before they enter the systemic circulation. If the capacity of the liver to metabolize a drug is extremely high, The drug can be completely inactivated on its first pass through the liver. As a result, no therapeutic effect can occur. To circumvent the first pass effect, a drug that undergoes rapid hepatic metabolism is often administered parenterally. This permits the drug to temporarily bypass the liver, thereby allowing it to reach the therapeutic levels in the systemic circulation before being metabolized. Nutritional status. Hepatic drug metabolizing enzymes require a number of cofactors to function. In the malnourished patient, these cofactors may be deficient, causing drug metabolism to be compromised. The competition between drugs. When two drugs are metabolized by the same metabolic pathway, they may compete with each other for metabolism and may thereby decrease the rate at which one or both agents are metabolized. If metabolism is depressed enough, a drug can accumulate to dangerous levels. So that brings us to the enterohepatic recirculation. As noted earlier and depicted in figure 4.6, the enterohepatic recirculation is a repeating cycle in which a drug is transported from the liver into the duodenum and then back to the liver. It is important to note, however, that only certain drugs are affected. Specifically, the process is limited to drugs that have undergone gluco glucuronidation, a process that converts lipid-soluble drugs to water-soluble drugs by binding them to glucuronic acid. After glucuronidation, oh my god, these drugs can enter the bile and then pass to the duodenum. In the intestine, some drugs can be hydrolyzed by intestinal beta-glucuronidase, an enzyme that breaks the bond between the original drug and glucuronide moiety, thereby releasing the free drug. Because the free drug is more lipid soluble than the glucuronidated form, the free drug can undergo reabsorption across the intestinal wall, followed by transport back to the liver, where the cycle can start again. Because of enterohepatic recycling, drugs can remain in the body much longer than they otherwise would. So here you're taking a look at how that would be in picture form. Excretion. Drug excretion is defined as the removal of drugs from the body. Drugs and their metabolites can exit the body in urine, bile, sweat, saliva, breast milk, and expired air. The most important organ for drug excretion are the kidneys. Renal drug excretion. The kidneys account for the majority of drug excretion. When the kidneys are healthy, they serve to limit the duration of action of many drugs. Conversely, if renal failure occurs, both the duration and intensity of drug responses may increase. Steps in renal drug excretion include the urinary excretion is the net result of three processes: glomerular filtration, passive tubular reabsorption, and active tubular secretion. So, glomerular filtration. The renal excretion begins at the glomerulus of the kidney tubule. As blood flows through the glomerular capillaries, fluid and small molecules, including drugs, are forced through the pores of the capillary wall. This process, called glomerular filtration, moves drugs from the blood into the tubular urine. Blood cells and large molecules are too big to pass through the capillary pores and therefore do not undergo filtration. Because large molecules are not filtered, drugs bound to albumin remain in the blood. Passive tubular reabsorption. As depicted in figure 4.7, the vessels that deliver blood to the glomerulus return to the proximity with the renal tubule at a point distal to the glomerulus. At this distal site, drug concentrations in the blood are lower than drug concentrations in the tubule. This concentration gradient acts as a driving force to move drugs from the lumen of the tubule back into the blood. because lipid-soluble drugs can't readily cross the membranes that compose the tubular and vascular walls. Drugs that are lipid-soluble undergo passive reabsorption from the tubule back into the blood. In contrast, drugs that are not lipid-soluble remain in the urine to be excreted. So here's a picture of glomerular filtration, the passive reabsorption, and the active transport. Good spot to hit pause to review your anatomy. Active tubular secretion. There are active transport systems in the kidney tubules that pump drugs from the blood to the tubular urine. These pumps have a relatively high capacity and play a significant role in the excretion of certain compounds. So factors that modify renal drug excretion. Renal drug excretion varies from patient to patient. Conditions such as chronic renal disease may cause profound alterations. Three other important factors to consider are pH-dependent ionization, competition for active tubular transport, and the patient's age. So, pH-dependent ionization. The phenomenon of pH-dependent ionization can be used to accelerate renal excretion of drugs. Recall that passive tubular reabsorption is limited to lipid-soluble compounds. Because ions are not lipid-soluble, drugs that are ionized at the pH of tubular urine will remain in the tubule and be excreted. Consequently, by manipulating urinary pH in such a way as to promote the ionization of a drug, we can decrease passive reabsorption back into the blood and can thereby hasten the drug's elimination. This principle has been employed to promote the excretion of poisons, as well as medications that have been taken in toxic doses. Competition for active tubular transport. Competition between drugs for active tubular transport can delay renal excretion, thereby prolonging effects. The active transport system of the renal tubules can be envisioned as a motor-driven revolving door that carries drugs from the plasma into the renal tubules. These revolving doors can carry only a limited number of drug molecules per unit of time. Accordingly, if there are too many molecules present, some must wait their turn. Because of competition, if we administer two drugs at the same time, and if both drugs use the same transport system, excretion of each will be delayed by the presence of the other. And again, age. The kidneys of newborns are not fully developed. Until their kidneys reach full capacity, infants have a limited capacity to excrete drugs. This must be accounted for when medicating an infant. In old age, renal function often declines. Older adults have smaller kidneys and fewer nephrons. The loss of nephrons results in decreased blood filtration. Additionally, vessel changes such as atherosclerosis reduce renal blood flow. As a result, renal excretion of drugs is decreased. Non-renal routes of drug excretion. In most cases, excretion of drugs by non-renal routes has minimally declined significantly. However, in certain situations, non-renal excretion can have important therapeutic and toxicologic consequences. Breast milk. Some drugs taken by breastfeeding mothers can undergo excretion into milk. As a result, breastfeeding can expose the nursing infant to drugs. The factors that influence the appearance of drugs in breast milk are the same factors that determine the passage of drugs across membranes. Accordingly, lipid-soluble drugs have ready access to breast milk, whereas drugs that are polar, ionized, or protein-bound cannot enter the significant amounts. Other non-renal routes of excretion. The bile is an important route of excretion for certain drugs. Because bile is secreted into the small intestine, drugs that do not undergo enterohepatic recirculation leave the body in the feces. The lungs are a major route by which volatile anesthetics are excreted. Alcohol is partially eliminated by this route. Small amounts of drugs can appear in sweat and saliva. These rounds have little therapeutic or toxicologic significance. Time course of drug response. It is possible to regulate the time at which drug responses start, the time they are most intense, and the time that they cease. Because the four pharmacokinetic processes, absorption, distribution, metabolism, and excretion, determine how much drug will be at its site of action at any given time, these processes are a major determinant of the time course over which drug responses take place. Plasma drug levels. In most cases, the time course of a drug action bears a direct relationship to the concentration of a drug in the blood. Hence, before discussing the time course per se, we need to review several important concepts related to plasma drug levels. Clinical significance of plasma drug levels. Providers frequently monitor plasma drug levels in efforts to regulate drug responses. When measurements indicate that drug levels are inappropriate, these levels can be adjusted up or down by changing dosage size, dosage timing, and or both. The practice of regulating plasma drug levels to control drug responses should seem a bit odd, given that drug responses are related to drug concentrations at sites of action, and the site of action of most drugs is not in the blood. More often than not, it is practically impossible to measure drug concentrations at sites of action. Experiences have shown that, for most drugs, there is a direct correlation between therapeutic and toxic responses and the amount of drug present in plasma. Therefore, although we cannot usually measure drug concentrations at sites of action, we can determine plasma drug concentrations that, in turn, are highly predictive of therapeutic and toxic responses. Accordingly, the dosing objective is commonly spoken of in terms of achieving a specific plasma level of a drug. Two plasma drug levels defined. Two plasma drug levels are of a special importance: a minimum effective concentration and the toxic concentration. These levels are depicted in the following figure, so here's a good spot to hit pause so you can review that. Minimum effective concentration. The minimum effective concentration, or MEC, is defined as the plasma drug level below which therapeutic effects will not occur. Hence, to be a benefit, a drug must be present in concentration at or above the MEC. Toxic concentrations. Toxicity occurs when the plasma drug level climbs too high. The plasma level at which toxic effects begin is termed the toxic concentration. Doses must be kept small enough so that the toxic concentration is not reached. So, we have therefore a therapeutic range. As indicated in the following figure 4.8, there is a range of plasma drug levels falling between the MEC and toxic concentration, which is termed the therapeutic range. When plasma levels are within the therapeutic range, there is enough drug present to produce therapeutic responses, but not so much that toxicity can result. The objective of drug dosing is to maintain plasma drug levels within that therapeutic range. The width of the therapeutic range is a major determinant of the ease with which a drug can be used safely. Drugs that have a narrow therapeutic range are difficult to administer safely. Conversely, drugs that have a wide therapeutic range can be administered safely with relative ease. The principle is the same as that of the therapeutic index that was discussed in Chapter 3. The therapeutic range is quantified or measured by the therapeutic index. Understanding this concept of therapeutic range can facilitate patient care because drugs with a narrow therapeutic range are more dangerous than drugs with a wide therapeutic range. Patients taking drugs with a narrow therapeutic range are more likely to require intervention for drug-related complications. The provider, who is aware of this, can focus additional attention on monitoring these patients for signs and symptoms of toxicity. So, a single dose time course. Again, figure 4.8 shows how plasma drug levels change over time after a single dose of the oral medication. Drug levels rise as the medication undergoes absorption. Drug levels then decline as metabolism and excretion eliminate the drug from the body. Because responses cannot occur until plasma drug levels have reached the MEC, there is a latent period between the drug administration and onset of effect. The extent of this delay is determined by the rate of absorption. The duration of effects is determined largely by the combination of metabolism and excretion. As long as drug levels remain above the MEC, therapeutic response will be maintained. When levels fall below the MEC, benefits will cease. Because metabolism and excretion are the process most responsible for causing plasma drug levels to fall, these processes are the primary determinants of how long drug effects will persist. Bringing us to the drug half-life. Before proceeding to the topic of multiple dosing, we need to discuss the concept of half-life. When a patient ceases drug use, the combination of metabolism and excretion will cause the amount of drug in the body to decline. The half-life of a drug is an index of how rapidly that declines, or the decline occurs for most drugs. A few agents, most notably ethanol or alcohol, leave the body at a constant rate, regardless of how much is present. The implications of this kind of decline for ethanol are discussed in Chapter 31. Drug half-life is determined as the time required for the amount of drug in the body to decrease by 50%. A few drugs have half-lives that are extremely short, on order of minutes or less. In contrast, half-lives of some drugs exceed up to 1 week. Note that in our definition of half-life, a percentage, not a specific amount, of drug is lost during one half-life. That is, the half-life does not specify, for example, that 2 gram or 80 milligram will leave the body at any given time. Rather, the half-life tells us that no matter what the amount of drug in the body may be, half, or 50%, will leave during a specific period of time, the half-life. The actual amount of drug that is lost during one half-life depends on just how much drug is present, or more drug is in the body, the larger the amount lost during one half-life. The concept of half-life is best understood through an example. Morphine provides a good illustration. The half-life of morphine is approximately 3 hours. By definition, that means the body stores of morphine will decrease by 50% every 3 hours, regardless of how much morphine is in the body. If there are 50 milligrams of morphine in the body, 25 milligrams will be lost in 3 hours. If there are only 2 milligrams of morphine in the body, only 1 milligram will be lost in 3 hours. Note that in both cases, morphine drops by 50% during an interval of one half-life. However, the actual amount lost is larger when total body stores of the drug are higher. The half-life of the drug determines the dosing interval. For drugs with a short half-life, the dosing interval must be correspondingly short. If a long dosing interval is used, drug levels will fall below the MEC. Between doses, the therapeutic effect will be lost. Conversely, if the drug has a long half-life, a long time can separate doses without the loss of the benefit. Drug levels produced with repeated doses. Multiple dosing leads to drug accumulation. When a patient takes a single dose of a drug, plasma levels simply go up and then go back down. In contrast, when a patient takes repeated doses of a drug, the process is more complex and results in drug accumulation. The factor that determines the rate and extent of accumulation are considered next. The process by which the plateau during levels are achieved. Administering repeated doses will cause a drug to build up in the body until a plateau has been achieved. What causes drug levels to reach a plateau, though? If a second dose of the drug is administered before all of the prior dose has been eliminated, total body stores of that drug will be higher after the second dose than the initial dose. As succeeding doses are administered, drug levels will climb even higher. The drug will continue to accumulate until a state has been achieved in which the amount of drug eliminated between doses equals the amount administered. When the amount of drug eliminated between doses equals the dose administered, average drug levels will remain constant and the plateau will have been reached. So here's a picture of the plateau. Time to plateau. When a drug is administered repeatedly in the same dose, plateau will be reached in approximately 4 half-lives for the hypothetical agent, illustrated in figure 4.9. Total body stores approached their peak near the beginning of day 5, or approximately 4 full days after treatment began, because the half-life of this drug is 1 day. Reaching plateau in 4 days is equivalent to reaching plateau in 4 half-lives. As long as dosage remains constant, the time required to reach plateau is independent of dosage size. Put another way, the time required to reach plateau when giving repeated large doses of a particular drug is identical to the time required to reach plateau when given repeated small doses of that drug. Referring to the drug in figure 4.9, just as it took 4 half-lives or 4 days to reach plateau when a dose of 2 grams was administered daily, it would also take 4 half-lives to reach the plateau if a dose of 4 grams were administered daily. It is true that the height of the plateau would be greater if a 4-gram dose were given, but the time required to reach plateau would not be altered by the increase in dosage. To confirm the statement, substitute a dose of 4 grams in the previous exercise and see when the plateau is reached. So if you look at it, it would still jump up at day 4, or at the end of the 4th half-life, sorry. Techniques for reducing fluctuations in drug levels. As illustrated in figure 4.9, when a drug is administered repeatedly, its level will fluctuate between doses. The highest level is referred to as the peak concentration, and the lowest level is referred to as the trough concentration. The acceptable height of the peak and the trough will depend on the drug's therapeutic range. The peak must be kept below the toxic concentration and the trough must be kept above the MEC. If there is not much difference between the toxic concentration and the MEC, then fluctuations must be kept to a minimum. 3 techniques can be employed to reduce fluctuations in drug levels. One technique is to administer drugs by continuous infusion. With this procedure, plasma levels can be kept nearly constant. Another is to administer a depot preparation, which releases the drug slowly and steadily. The third is to reduce both the size of each dose and the dosing interval. So, for example, rather than giving the drug from figure 4.9 in 2-gram doses once every 24 hours, it would be given this drug in 1-gram doses every 12 hours. With this alternating dosing schedule, the total daily dose would remain unchanged, as would total body stores at plateau. However, instead of fluctuating over a range of 2 grams between the dose, levels would fluctuate over the range of 1 dose. The loading dose versus the maintenance dose. As discussed previously, if we administer a drug in a repeated dose of equal size, an interval equivalent to about 4 half-lives is required to achieve plateau. When plateau must be achieved more quickly, a large initial dose can be administered. This large initial dose is called the loading dose. After a high drug level have been established for the loading dose, plateau can be maintained by giving smaller doses. These smaller doses are referred to as the maintenance dose. The claim that use of loading dose will shorten the time to plateau may appear to contradict an earlier statement, which said that the time to plateau is not affected by dosage size. However, there are no contradictions. For any specific dosage, it will always take about 4 half-lives to reach the plateau. When a loading dose is administered, followed by the maintenance dose, the plateau is not reached for the loading dose. Rather, we have simply used the loading dose to rapidly produce a drug level equivalent to the plateau level rather for a smaller dose. To achieve plateau level for the loading dose, it would be necessary to either administer repeated doses equivalent to the loading dose for a period of 4 half-lives, or administer a dose even larger than the original loading dose. A decline from plateau. When drug administration is discontinued, most 94% of the drug in the body will eliminate over an interval equal to about 4 half-lives. The time required for drugs to leave the body is important when toxicity develops. If a drug has a short half-life, body stores will decline rapidly, thereby making management of overdoses less difficult. When an overdose of a drug with a long half-life occurs, however, toxic levels of the drug will remain in the body for a long time. Additional management may be needed in these instances. Bringing us to pharmacodynamics. Pharmacodynamics. Pharmacodynamics is the study of biochemical and physiological effects of drugs on the body and the molecular mechanism by which those effects are produced. To participate rationally in achieving the therapeutic objective, an understanding of pharmacodynamics is essential. Dose-response relationships. The dose-response relationship, i.e., the relationship between the size of the administered dose and the intensity of the response produced, is a fundamental concern in therapeutics. Dose-response relationships determine the minimal amount of drug needed to elicit a response, the maximal response a drug can elicit, and how much to increase the dosage to produce the desired increase in response. Basic features of the dose-response relationship. The basic characteristics of dose-response relationship are illustrated in the following figure. Part A shows dose-response data plotted in linear coordinates. Part B shows the same data plotted in semi-logarithmic coordinates. The most obvious and important characteristics revealed by the curves is that the dose-response relationship is graded. That is, as the dosage increases, the response becomes progressively larger. Because drugs' responses are graded, therapeutic effects can be adjusted to fit the needs of each patient by raising or lowering the dosage until a response of the desired intensity is achieved. So here you're taking a look at the basic components of the dose-response curve. A good spot to hit pause if you're unfamiliar with how this works. As indicated in Figure 410, the dose-response relationship can be viewed as having 3 phases. Phase 1 occurs at low dose. The curve is flat during this phase because doses are too low to elicit a measurable response. During Phase 2, an increase in dose elicits a corresponding increase in the response. This is the phase during which the dose-response relationship is graded. As the dose goes higher, eventually a point is reached where an increase in dose is unable to elicit a further increase in response. At this point, the curve flattens out into Phase 3. Maximal efficiency and relative potency. Dose-response curves reveal 2 characteristic properties of drugs, a maximal efficacy and a relative potency that reflects these properties and are shown in the following figure. So here you're taking a look at the dose-response curves demonstrating efficacy and potency. Maximal efficacy. Maximal efficacy is defined as the largest effect that a drug can produce. Maximal efficacy is indicated by the height of the dose-response curve. The concept of maximal efficacy is illustrated by the dose-response curves for meperidine, or Demerol, and pentazocine, or Talvin, 2 morphine-like pain relievers. As you can see, the curve of pentosylkene levels off at a maximal height below that of the curve of meperidine. This tells us that the maximal degree of pain relief we can achieve with pentazocine is smaller than the maximal degree of pain relief we can achieve with meperidine. Put another way, no matter how much pentazocine we administer, we can never produce the degree of pain relief that we can with meperidine. Accordingly, we would say that meperidine has greater maximal efficacy than pentazocine. Despite what intuition might tell us, a drug with very high maximal efficacy is not always more desirable than a drug with a lower efficacy. Recall that we want to match the intensity of the response to the patient's need. This may be difficult to do with a drug that produces extremely intense responses. For example, certain diuretics like Lasix have such high maximal efficacy that they can cause dehydration. If we only want to mobilize a modest volume of water, a diuretic with a lower maximal efficacy, like hydrochlorothiazide, would be preferred. Similar in a patient with a mild headache, we would not select a powerful analgesic for relief. Rather, we would select an analgesic with lower maximal efficacy, such as aspirin. Relative potency. The term potency refers to the amount of drug we must give to elicit an effect. Potency is indicated by the relative position of the drug response curve along the x-axis. The concept of potency is illustrated by the curves in Figure 4.11b. The curves plot doses for two analgesics, morphine and meperidine, versus the degree of pain relief achieved. As you can see, for any particular degree of pain relief, the required dose of meperidine is larger than the required dose of morphine. Because morphine produces pain relief at a lower doses than meperidine, we would say that morphine is more potent than meperidine. That is, a potent drug is one that produces its effects at low doses. Potency is rarely an important characteristic of a drug. The only consequence of having greater potency is that a drug with greater potency can be given in smaller doses. It is important to note that the potency of a drug implies nothing about its maximal efficacy. Potency and efficacy are completely independent qualities. Drug A can be more effective than drug B, even though drug B may be more potent. Also, drug A and B can be equally effective, even though one may be more potent. As we saw in Figure 4.11b, although meperidine happens to be less potent than morphine, the maximal degree of pain relief that we can achieve with these drugs is identical. A final comment on the word potency is in order. In everyday parlance, people tend to use the word potent to express the pharmacologic concept of effectiveness. That is, when most people say this drug is very potent, what they mean is this drug produces powerful effects. They do not mean this drug produces its effect at low doses. In pharmacology, we use words as potent and potency with a specific and appropriate terminology. So, drug receptor interactions. Introduction to drug receptors. Drugs produce their effects by interacting with other chemicals. Receptors are the special chemical sites in the body that most drugs interact with to produce effects. We can define a receptor as a functional macromolecule in a cell to which a drug binds to produce its effects. However, although the formal definition of a receptor encompasses all functional macromolecules, the term receptor is generally reserved for the body's own receptors, for hormones, neurotransmitters, and other regulatory molecules. The other macromolecules in which drugs bind, such as enzymes and ribosomes, can be thought of simply as target molecules, rather than true receptors. Binding of a drug to its receptor is usually reversible. Receptors are activated by interaction by other molecules. Under physiologic conditions, endogenous compounds are the molecules that bind to receptors to produce a response. When a drug is the molecule that binds to a receptor, all that it can do is mimic or block the actions of endogenous regulatory molecules. By doing so, the drug will either increase or decrease the rate of physiologic activity, normally controlled by that receptor. Because drug action is limited to mimicking or blocking the body's own regulatory molecules, drugs cannot give new function. In other words, drugs cannot make the body do anything that it is not already capable of doing. So here you're taking a look at the interactions of drugs. Receptors and selectivity of drug action. Selectivity, the ability to elicit only the response for which a drug is given, is highly desirable characteristic of a drug, in that the more selective a drug is, the fewer side effects it will produce. Selective drug action is possible in large part because drugs act through specific receptors. There are receptors for each neurotransmitter. There are receptors for each hormone, and there are receptors for all of the other molecules the body uses to regulate physiologic processes. As a rule, each type of receptor participates in the regulation of just a few processes. If a drug interacts with only one type of receptor, and if that receptor type regulates just a few processes, then the effects of the drug will be limited. Conversely, if a drug interacts with several different receptor types, then that drug is likely to elicit a wide variety of responses. So here you see the four primary receptor families: the cell membrane embedded enzyme, the ligand gated ion channel, the G protein coupled receptor system, and the transcription factor. So how can a drug interact with one receptor type and not the others? In some important ways, a receptor is analogous to a lock, and the drug is analogous to a key for that lock. Just as only keys with a proper profile can fit a particular lock, only those drugs with a proper size, shape, and physical property can bind to a particular receptor. So here you're taking a look at the acetylcholine receptor, the interaction of acetylcholine with its receptor. Theories of drug receptor interactions. In the discussion that follows, we consider two theories of drug receptor interactions: a simple occupancy theory and a modified occupancy theory. These theories help explain dose-response relationships and the ability of drugs to mimic or block the actions of endogenous regulatory molecules. Simple occupancy theory. The simple occupancy theory of drug receptor interaction states that the intensity of a response to a drug is proportional to the number of receptors occupied by the drug, and a maximal response will occur when all available receptors have been occupied. This relationship between receptor occupancy and the intensity of the response is depicted. So here you're taking a look at the model of the simple occupancy theory. Although certain aspects of dose-response relationships can be explained by the simple occupancy theory, other important phenomena cannot. Specifically, there is nothing in this theory to explain why one drug should be more potent than another. In addition, this theory cannot explain how one drug can have higher maximal efficacy than another. That is, according to this theory, two drugs acting at the same receptor should produce the same maximal effect, provided that their dosage were high enough to produce a 100% receptor occupancy. However, we have already seen this is not true. As illustrated in figure 4.11a, there is a dose of pentazocine above which no further increase in response can be elicited. Presumably, all receptors are occupied when the dose-response curve levels off. However, at 100% receptor occupancy, the response elicited by pentazocine is less than the elicited by meperidine. Simple occupancy theory cannot account for this difference, which leads us to the modified occupancy theory. A modified occupancy theory of drug-receptor interaction explains certain observations that cannot be accounted for with the simple occupancy theory. The modified theory ascribes two qualities to drugs: affinity and intrinsic activity. The term affinity refers to the strength of the attraction between the drug and its receptor. Intrinsic activity refers to the ability of the drug to activate the receptor after binding. Affinity and intrinsic activity are independent properties. So, affinity. Affinity, as noted, the term affinity refers to the strength of the attraction between the drug and its receptor. Drugs with high affinity are strongly attracted to their receptors. Conversely, drugs with low affinity are weakly attracted. The affinity of a drug for its receptor is reflected in its potency. Because they are strongly attracted to the receptor, drugs with high affinity can bind to their receptors when present in low concentrations. Because they bind to their receptors at low concentrations, drugs with high affinity are effectively in low doses. That is, drugs with high affinity are very potent. Conversely, drugs with low affinity must be present in high concentrations to bind to their receptors. Accordingly, the drugs are less potent, leading us to the intrinsic activity. The term intrinsic activity refers to the ability of a drug to activate a receptor upon binding. Drugs with a high intrinsic activity cause intense receptor activation. Conversely, drugs with low intrinsic activity cause only slight activation. The intrinsic activity of a drug is reflected in its maximal efficacy. Drugs with high intrinsic activity have high maximal efficacy. That is, by causing intense receptor activation, they are able to cause intense responses. Conversely, if intrinsic activity is low, maximal efficacy will be low as well. It should be noted that under the modified occupancy theory, the intensity of the response to a drug is still related to the number of receptors occupied. The wrinkle added by the modified theory is that intensity is also related to the ability of the drug to activate receptors after binding has occurred. Under the modified theory, two drugs can occupy the same number of receptors, but produce effects of different intensity. The drug with greater intrinsic activity will produce the more intense response. Which brings us to our agonists, antagonists, and partial agonists. As previously noted, when drugs bind to receptors, they can do one of two things. They can either mimic the action of the endogenous regulatory molecules, or they can block the action of the endogenous regulatory molecules. Drugs that mimic the body's own regulatory molecules are called agonists. Drugs that block the action of endogenous regulators are called antagonists. Like agonists, partial agonists also mimic the action of endogenous regulatory molecules, but they produce responses of intermediate intensity. So, speaking of agonists, agonists are molecules that activate receptors. Because neurotransmitters, hormones, and other endogenous regulators activate the receptor to which they bind, all of these compounds are considered agonists. When drugs act as agonists, they simply bind to receptors and mimic the action of the body's own regulatory molecules. Dobutamine, for example, is a drug that mimics the action of norepinephrine at receptors on the heart, thereby causing heart rate and force of contraction to increase. In terms of the modified occupancy theory, an agonist is a drug that has both affinity and high intrinsic activity. Affinity allows the agonist to bind to receptors, whereas the intrinsic activity allows the bound agonist to activate or turn on the receptor function. So, then leads us to the opposite side of it, the antagonists. Antagonists produce their effects by preventing receptor activation by endogenous regulatory molecules and drugs. Antagonists have virtually no effect of their own on receptor function. In terms of the modified occupancy theory, an antagonist is a drug with affinity for a receptor, but with no intrinsic activity. Affinity allows the antagonist to bind to receptors, but lack of intrinsic activity prevents the bound antagonist from causing receptor activation. Although antagonists do not cause receptor activation, they most certainly do produce pharmacologic effects. Antagonists produce their effects by preventing the activation of receptors by endogenous regulatory molecules. Antihistamines, for example, are histamine receptor antagonists that suppress allergy symptoms by binding to receptors for histamine, thereby preventing activation of these receptors by histamine released in response to allergens. It is important to note that the response to an antagonist is determined by how much agonist is present. Because antagonists act by preventing receptor activation, if there is no agonist present, Administration of an antagonist will have no observable effect. The drug will bind to its receptor, but nothing will happen. On the other hand, if receptors are undergoing activation by agonists, administration of an antagonist will shut the process down, resulting in an observable response. An example is the use of an opioid antagonist naloxone, which is used to block opioid receptors in the event of an opioid overdose. Antagonists can be subdivided into two major classes: non-competitive antagonists and the competitive antagonists. Most antagonists are considered competitive. However, let's discuss the non-competitive, insurmountable antagonists. Non-competitive antagonists bind irreversibly to receptors. The effect of irreversible binding is equivalent to reducing the total number of receptors available for activation by an agonist. Because the intensity of the response to an agonist is proportional to the total number of receptors occupied, and because non-competitive antagonists decrease the number of receptors available for activation, non-competitive antagonists reduce the maximal response that an agonist can elicit. If sufficient antagonist is present, agonist effects will be blocked completely. Dose response curves illustrating inhibition by a non-competitive antagonist are shown in the following figure. So here you're taking a look at the dose response curves in the presence of a competitive and a non-competitive antagonist. Because the binding of a non-competitive antagonist is irreversible, inhibition of these agents cannot be overcome, no matter how much agonists may try to, and may be available. Although non-competitive antagonists bind irreversibly, this does not mean that their effects last forever. Cells are constantly breaking down, old receptors are synthesizing new ones. Consequently, the effects of a non-competitive antagonist eventually wear off, as the receptors to which they are bound or are replaced. Because the life cycle of a receptor can be relatively short, the effects of non-competitive antagonists may subside in a few days. Still, this can be a long time for some functions. Therefore, these agonists are rarely used therapeutically. Bringing us to the competitive antagonist, the surmountable type. Competitive antagonists bind reversibly to receptors. As their name implies, competitive antagonists produce receptors blockade by competing with agonists for receptor binding. If an agonist and a competitive antagonist have equal affinity for a particular response, then the receptor will be occupied by whichever agent, whether it's the agonist or antagonist, is present in the highest concentration. If there are more antagonist molecules present than the agonist molecules, antagonist molecules will occupy that receptor and the receptor activation will be blocked. And conversely, if the agonist molecules outnumber the antagonist, then the receptor will be occupied mainly by the agonist and little inhibition will occur. Because the competitive antagonists bind reversibly to receptors, the inhibition they cause is surmountable. In the presence of sufficiently high amounts of agonist molecules will occupy all receptors and inhibition will be completely overcome. The dose-response curves, shown in figure 4.16b, illustrates the process of overcoming the effects of a competitive antagonist with large doses of an agonist. Partial agonists. A partial agonist is an agonist that has only moderate intrinsic activity. As a result, the maximal effect that a partial agonist can produce is lower than that of a full agonist. Bringing us back to the pentazocine example, that is a partial agonist. As the curves in figure 411 indicate, the degree of pain relief that can be achieved with pentazocine is much lower than the relief that can be achieved with meperidine, which is a full agonist. Partial agonists are interesting in that they can act as an antagonist as well as an agonist. For this reason, they are sometimes referred as agonist-antagonist. For example, when pentazocine is administered by itself, it occupies opioid receptors and produces moderate relief of pain. In this situation, the drug is acting as an agonist. However, if a patient is already taking meperidine, and is then given a large dose of pentazocine. Pentazocine will occupy the opioid receptors and prevent their activation by meperidine. As a result, rather than experiencing a high degree of pain relief the meperidine can produce, the patient will experience only a limited relief that pentazocine can produce. In this situation, pentazocine is acting as both an agonist and an antagonist. The regulation of receptor sensitivity, therefore. Receptors are dynamic components in the cell. In response to continuous activation or continuous inhibition, the number of receptors on the cell surface can change, as can their sensitivity to agonist molecules. For example, when the receptors of a cell are continually exposed to an agonist, the cell usually becomes less responsive. When this occurs, the cell is said to desensitize or refractory, or to have undergone downregulation. Several mechanisms may be responsible, including the destruction of receptors by the cell and modification of receptors such that they respond less fully. Continuous exposure to antagonists has the opposite effect, causing the cell to become hypersensitive. One mechanism that can cause hypersensitivity is synthesis of more receptors. So, the drug responses that do not involve receptors. Although the effect of most drugs result from drug-receptor interactions, some drugs do not act through receptors. Rather, they act through simple physical or chemical interactions with other small molecules. Common examples of these drugs include antacids, antiseptics, saline laxatives, and chelating agents. Antacids neutralize gastric acidity by direct chemical interaction with the stomach acid. The antiseptic action of ethyl alcohol results from precipitating bacterial proteins. Magnesium sulfate, a powerful laxative, acts by retaining water in the intestinal lumen through an osmotic effect. Dimercaprol, a chelating agent, prevents toxicity from heavy metals, such as arsenic and mercury. By forming complexes with these compounds, all of these pharmacologic effects are the result of simple physical or chemical interactions, and not interactions with a cellular receptor. So, the interpatient variable in drug response. The dose required to produce a therapeutic response can vary substantially from patient to patient because people differ from one another. In this section, we consider interpatient variation as a general issue. The specific kinds of differences that underlie variability in drug responses are discussed further in Chapter 6. To promote the therapeutic objective, you must be alert to interpatient variation in drug responses. Because of interpatient variation, it is not possible to predict exactly how an individual patient will respond to a medication. The provider who appreciates the reality of interpatient variability will be better prepared to anticipate, evaluate, and respond appropriately to each patient's therapeutic need. So, the following figure, 4.17, illustrates an example of interpatient variability in response to a drug. Figure 4.17a represents incremental increases in the milligram dose of drug to elevate gastric pH, coupled with the number of patients who had a therapeutic response at each dose. In figure 4.7b, these results are plotted in a frequency distribution curve. We can see from the curve that a wide range of doses is required to produce the desired response in all subjects. For some subjects, a dose of only 100 milligrams was sufficient to produce the target response. For other subjects, the therapeutic endpoint was not achieved until the total dose totaled that of 240 milligrams. So here, if you want to take a look and pause, you can see how the interpatient variation in drug response relates. So the ED50, the dose at the middle of the frequency distribution curve, is termed the ED50. The ED50 is defined as a dose that is required to produce a defined therapeutic response in 50% of the population. In the case of the drug, in our example, the ED50 was 170 milligrams. The dose needed to elevate gastric pH to a value of 5 is 50% of the 100 people tested. The ED50 can be considered a standard dose, and as such is frequently the dose selected for initial treatment. After evaluating a patient's response to the standard dose, we can then adjust subsequent doses either up or down to meet the patient's need. Clinical implications of interpatient variability. Interpatient variation has four important clinical consequences. As a provider, you should be aware of these implications. The initial dose of a drug is necessarily an approximation. Subsequent doses may be needed to fine-tune based on the patient's response. When given an average effective dose, the ED50, some patients will be undertreated, whereas others will receive more drug than they need. Accordingly, when the therapy is initiated with a dose equivalent to the ED50, it is especially important to evaluate the response. Patients who fail to respond may need an increase in dosage. Conversely, patients who show signs of toxicity will need a dose reduction. Because drug responses are not completely predictable, you must monitor the patient's response for both positive effects and adverse effects to determine whether too much or too little medication has been administered. In other words, dosage should be adjusted on the basis of the patient's response and not on the basis of clinical guideline. Bringing us to the therapeutic index. The therapeutic index is a measure of drugs' safety. The therapeutic index is defined as the ratio of a drug's LD to its ED. The LD is the average lethal dose. It is the dose that is lethal to 50% of subjects treated. A large therapeutic index indicates that a drug is relatively safe. Conversely, a small therapeutic index indicates that a drug is relatively unsafe. The concept of therapeutic index is illustrated by the frequency distribution curves in Figure 4.18. Part A of the figure shows curves for therapeutic and lethal responses to drug X. Part B shows equivalent curves for drug Y. As you can see, the average lethal dose for drug X is much larger than the average therapeutic dose. Because this drug's lethal dose is much larger than its therapeutic dose, common sense tells us that the drug should be relatively safe. The safety of this drug is reflected in its high therapeutic index, which is 10. In contrast, drug Y is unsafe. As shown in the figure, the average lethal dose for drug Y is 20 milligrams, which is only twice the average therapeutic dose. Hence, drug Y, at dose only twice the ED, could be lethal to 50% of those treated. Clearly, drug Y is not safe. This lack of safety is reflected in its low therapeutic index. So here I'll leave this figure up so you can kind of look at it and you can compare it. The curves for drug Y indicate and illustrate a phenomenon that is even more important than the therapeutic index. As you can see, there is overlap between the curves for therapeutic effect and the curve for lethal effects. This overlap tells us that a high dose needed to produce therapeutic effects in some people may be large enough to cause death in others. The message here is that if a drug is to be truly safe, the highest dose required to produce a therapeutic effect must be substantially lower than the lowest dose required to produce death. Which brings us to the drug interaction. Drug-to-drug interactions. Drug-to-drug interactions can occur when a patient takes two or more drugs. Some interactions are both intended and desired, as when we combine drugs to treat hypertension. In contrast, some interactions are both unintended and undesired. So the consequences of drug-to-drug interactions. When two drugs interact, there are three possible outcomes. One drug may intensify the effects of the other, one drug may reduce the effects of the other, and the combination may produce a new response not seen when either drug alone is used. Intensification of effects. When one drug intensifies or potentiates the effects of the other, this type of interaction is often termed potentiative. Potentiative interactions may be beneficial or detrimental. Increased therapeutic effects. The interaction between the sulbactam and ampicillin represents a beneficial potentiative interaction. When administered alone, ampicillin undergoes rapid inactivation by bacterial enzymes. Sulbactam inhibits those enzymes and thereby prolongs and intensifies ampicillin's therapeutic effect. Increased adverse effects. The interaction between aspirin and warfarin represents a potential detrimental potentiative interaction. Both aspirin and warfarin suppresses the formation of blood clots. Aspirin does this through antiplatelet activity, and warfarin does it through the anticoagulant activity. As a result, if aspirin and warfarin are taken concurrently, the risk for bleeding is significantly increased. The reduction of effects. Interactions that result in reduced drug effects are often termed inhibitory. As with potentiative interactions, inhibitory interactions can be beneficial or detrimental. Inhibitory interactions that reduce toxicity are beneficial. Conversely, inhibitory interactions that reduce therapeutic effects are detrimental. Reduced therapeutic effects. The interaction between propranolol and albuterol represents detrimental inhibitory interaction. Albuterol is taken by people with asthma to dilate the bronchi. Propranolol, a drug for cardiovascular disorders, can act in the lungs to block the effects of albuterol. Hence, propranolol and albuterol are taken together. Propranolol can reduce albuterol's therapeutic effect. So, reduced adverse effects. The use of naloxone to treat morphine overdose is an example of beneficial inhibitory interactions. Quite the excellent example. When administered in excessive dosage, morphine can produce coma, profound respiratory depression, and eventual death. Naloxone, or Narcan, blocks morphine's actions and can completely reverse all symptoms of toxicity. The creation of unique responses. Rarely, the combination of two drugs produces a new response not seen with either agent alone. To illustrate, let's consider the combination of alcohol with disulfiram, the antabuse, a drug used to treat alcoholism. When alcohol and disulfiram are combined, a host of unpleasant and dangerous responses can result. However, these effects do not occur when disulfiram or alcohol is used alone. So, the basic mechanisms of drug-to-drug interaction, therefore. Drugs can interact through four basic mechanisms: direct chemical or physical interaction, pharmacokinetic interaction, pharmacodynamic interaction, and the combined toxicity. So, direct chemical or physical interactions. Some drugs, because of their physical or chemical properties, can undergo direct interaction with other drugs. Direct physical and chemical interactions usually render both drugs inactive. Direct interaction occurs most commonly when drugs are combined in IV solutions. Frequently, the interaction produces a precipitate. However, direct drug interactions may not always leave visible evidence. Hence, you cannot rely on simple inspection to reveal all direct interactions. Because drugs can interact in solution, it is essential to consider and verify drug incompatibilities when ordering medications. The same kind of interactions that can take place when drugs are mixed together in an IV solution can also occur when incompatible drugs are taken by other routes. However, because drugs are diluted in body water after administration, and because dilution decreases chemical interactions, significant interaction within the patient are much less likely than an IV solution. Pharmacokinetic interactions. Drug interactions can affect all four of the basic pharmacokinetic processes. That is, when the two drugs are taken together, one may alter the absorption, distribution, metabolism, or excretion of the other. So, altered absorption. Drug absorption may be enhanced or reduced by drug interactions. There are several mechanisms by which one drug can alter the absorption of another. By elevating gastric pH, antacids can decrease the ionization of basic drugs in the stomach, increasing the ability of basic drugs to cross membranes and be absorbed. Antacids have the opposite effect on acidic drugs. Laxatives can reduce absorption of other oral drugs by accelerating their passage through the intestine. Drugs that depress peristalsis prolong drug transit time in the intestine, thereby increasing the time for absorption. Drugs that induce vomiting can decrease absorption of oral drugs. Orally administered absorbent drugs that do not undergo absorption can absorb other drugs onto themselves, thereby preventing absorption of other drugs into the blood. Drugs that reduce regional blood flow can reduce absorption of other drugs from the region. For example, when epinephrine is injected together with a local anesthetic, the epinephrine causes local vasoconstriction, thereby reducing regional blood flow and delaying absorption of the anesthetic. Altered distribution. There are two principal mechanisms by which one drug can alter the distribution of another: competition for protein binding and alteration of extracellular pH. The competition for protein binding. When two drugs bind to the same site on plasma albumin, co-administration of those drugs produces competition for binding. As a result, binding of one or both agents is reduced, causing plasma levels of free drug to rise. In theory, the increase in free drug can intensify effects. However, because the newly freed drug usually undergoes rapid elimination, the increase in plasma level of free drug is rarely sustained or significant unless the patient has liver problems that interfere with the drug metabolism or has renal problems that interfere with the drug excretion. The alteration of extracellular pH. A drug with the ability to change extracellular pH can alter the distribution of other drugs. For example, if a drug were to increase extracellular pH, that drug would increase the ionization of acidic drugs in extracellular fluids. As a result, acidic drugs would be drawn from within cells into the extracellular space. Hence, the alteration in pH would change drug distribution. The ability of drugs to alter pH and thereby alter the distribution of other drugs can be put to practical use in the management of poisoning, an example of which is some symptoms of aspirin toxicity can be reduced with sodium bicarbonate, a drug that elevates extracellular pH. By increasing the pH outside of cells, bicarbonate causes aspirin to move from the intracellular sites into the interstitial fluid and plasma, thereby minimizing injury to cells. The altered metabolism. Altered metabolism is one of the most important and most complex mechanisms by which drugs interact. Some drugs increase the metabolism of other drugs, and some drugs decrease the metabolism of other drugs. Drugs that cause an increase in the metabolism of other drugs do so by inducing the synthesis of hepatic drug metabolizing enzymes. Drugs that decrease the metabolism of other drugs do so by inhibiting those enzymes. So, as discussed earlier, the majority of drug metabolism is catalyzed by the cytochrome P450 enzyme, or P450, which are composed of a large number of isoenzyme families, again, that's CYP1 through 3, that are further divided into specific forms. The five isoenzyme forms are responsible for the metabolism of most drugs. Again, that's CYP1A2, CYP2C9, CYP2C19, and CYP2D6. And lastly, the CYP3A4. So, the following table lists major drugs that are metabolized by each isoenzyme and indicates drugs that can inhibit or induce those isoenzymes. Here is one of the best places to hit pause and make a little table for yourself and or print this table out if possible. Um, the inhibitors, the inducers, the substrates, and where they work in the CYP. I got a feeling we will definitely see how these would interact in other ways. So please pause, 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 Write these suckers down. You will need them. The induction of the CYP enzymes. In our discussion of metabolism earlier in the chapter, you learned about the induction of the CYP enzymes, but it is essential that an inducing agent is taken with another medicine. Dosage of those other medicines may need adjustment. For example, if a woman taking oral contraceptives were to begin taking phenobarbital, induction of drug metabolism by phenobarbital would accelerate metabolism of the contraceptive, thereby lowering its level. If drug metabolism were increased enough, protection against pregnancy would be lost. To maintain contraceptive efficacy, dosage of the contraceptives should be increased. Conversely, when a patient discontinues an inducing agent, dosages of other drugs may need to be lowered. If dosage is not reduced, drug levels may climb dangerously high as rates of hepatic metabolism decline to the baseline values. The inhibition of the CYP enzymes. If drug A inhibits the metabolism of drug B, then levels of drug B will rise. The result may be beneficial or harmful. The interactions of ketoconazole, an antifungal drug, and cyclosporin, an expensive immunosuppressant, provides an interesting case in point. Ketoconazole inhibits the CYP3A4 and the CYP isoenzyme that metabolizes cyclosporins. If ketoconazole is combined with cyclosporin, the serum drug level of cyclosporin will rise. In this instance, inhibition of the CYP3A4 allows us to achieve therapeutic drug levels at lower doses, thereby greatly reducing the cost of treatment. Although inhibition of a drug metabolism can be beneficial, as a rule, inhibition has undesirable results. That is, in most cases, when an inhibitor increases the level of another drug, the outcome is toxicity. Accordingly, when a patient is taking an inhibitor along with his or her other medicines, you should be alerted for possible adverse effects. Unfortunately, because the number of possible interactions of this type is large, keeping track is a challenge. The safest practice is to check for drug interactions in one of the reliable software applications that are widely available. So, altered renal excretion. Drugs can alter all three phases of renal excretion, whether it's through filtration, reabsorption, or active secretion. By doing so, one drug can alter the renal excretion of another. Glomerular filtration can be decreased by drugs that reduce cardiac output. A reduction in cardiac output decreases renal perfusion, which decreases drug filtration at the glomerulus, which in turn decreases the rate of drug excretion. By altering urinary pH, one drug can alter the ionization of another, and thereby increases or decreases the extent to which the drug undergoes passive tubular reabsorption. Finally, competition between two drugs for active tubular secretion can decrease the renal excretion of both agents. Interactions that involve the P-glycoprotein. As discussed previously in the chapter, the PGP is a transmembrane protein that transports a wide variety of drugs out of cells, including cells of the intestinal epithelium, the placenta, the BBB, the liver, and the kidney tubules. Like P450 isoenzymes, PGP is subject to induction and inhibition by drugs. In fact, most of the drugs that inhibit or induce P450 have the same effect as PGP. Drugs that induce PGP can have the following effects on other drugs: reduced absorption by increasing drug export from the cells of the intestinal epithelium into the intestinal lumen, reduced fetal drug exposure by increasing the drug export from placental cells into the maternal blood, reduced brain drug exposure by increasing drug exports from the cells of brain capillaries into the blood, and increased drug elimination by increasing the drug export from the liver into the bile and from renal tubular cells into the urine. Drugs that inhibit PGP will have an opposite effect. So, pharmacodynamic interactions. By influencing pharmacodynamic processes, one drug can alter the effects of another. Pharmacodynamic interactions are of two basic types: interactions in which the interacting drug act at the same site, and interactions in which the interacting drugs act at separate sites. Pharmacodynamic interactions may be potentiative or inhibitory and can be of great clinical significance. So, interactions at the same receptor. Interactions that occur at the same receptor are almost always inhibitory. Inhibition occurs when an antagonist drug blocks access of an agonist drug to its receptor. There are many agonist and antagonist interactions of clinical importance. Some reduce therapeutic effects and are therefore undesirable. Others reduce toxicity and are of obvious benefit. The interaction between naloxone and morphine noted previously is an example of a beneficial inhibitory interaction. By blocking access of morphine to its receptor, naloxone can reverse all symptoms of morphine overdose. Interactions resulting from actions at separate sites. Even though two drugs have different mechanisms of action and act at separate sites, if both drugs influence the same physiologic process, then one drug can alter responses produced by the other. Interactions resulting from effects produced at different sites may be potentiative or inhibitory. The interaction between morphine and diazepam illustrates a potentiative interaction resulting from concurrent use of drugs that act at separate sites. Morphine and diazepam are CNS depressants, but these drugs do not share the same mechanism of action. Hence, when these agents are administered together, the ability of each to depress CNS function reinforces the depressant effects of the other. This potentiative interaction can result in profound CNS depression. The interaction between two diuretics, hydrochlorothiazide and spironolactone, illustrates how the effect of a drug acting at one site can counteract the effect of a second drug acting at a different site. Hydrochlorothiazide acts on the distal convoluted tubule of a nephron to increase excretion of potassium. Acting at a different site in the kidney, aldactone works to decrease renal excretion of potassium. Consequently, when these two drugs are administered together, the potassium-sparing effects of aldactone tend to balance the potassium-wasting effects of hydrochlorothiazide, leaving renal excretion of potassium at about the same level it would have been had no drug been given at all. The combined toxicity. If drug A and drug B are both toxic to the same organ, then taking them together could cause major injury than if they were not combined. An example of this is when we treat tuberculosis with isoniazid and rifampin, both of which are hepatotoxic. The potential cause to liver injury is greater than it would be if we had used only one of the drugs. As a rule, drugs with overlapping toxicity are not used together. Unfortunately, when treating tuberculosis, the combination is essential. So sometimes we have to do what we have to do to treat our patients. Clinical significance of drug-to-drug interactions. Clearly, drug interactions have the potential to affect the outcome of therapy. As a result of drug-to-drug interactions, the intensity of response may be increased or reduced. Interactions that increase therapeutic effects or reduce toxicity or are desirable. Conversely, interactions that reduce therapeutic effects or increase toxicity are detrimental. Interactions are especially important for drugs that have a narrow therapeutic range. For these agents, an interaction that produces a modest increase in drug level can cause toxicity. Conversely, an interaction that produces a modest decrease in drug levels can cause therapeutic failure. Although a large number of important interactions have been documented, many more are yet to be identified. Therefore, if a patient develops unusual symptoms, It is wise to suspect that a drug interaction may be the cause, especially because yet another might be given to control the new symptom. Minimizing adverse drug-to-drug interactions. We can minimize adverse interactions in several ways. The most obvious is to minimize the number of drugs a patient receives. A second and equally important way to avoid detrimental interactions is to take a thorough drug history, a history that identifies all drugs the patient is taking, including illicit and over-the-counter preparations, allows the provider to adjust the regimen accordingly. Additionally, measures for reducing adverse interactions include adjusting the dosage when an inducer of metabolism is added to or deleted from the regimen, adjusting the timing of administration to minimize interference with absorption, monitoring for early signs of toxicity when combined or the combination of toxic agents cannot be avoided, and being especially vigilant when the patient is taking a drug with a very narrow therapeutic range. Which brings us to drug and food interactions. Drug food interactions are both important and poorly understood. They are important because they can result in toxicity or therapeutic failure. They are poorly understood because research has been largely lacking. Effects of food on drug absorption. So, again, we can have both ends, the decreased and increased. Decreased absorption. The food frequently decreases the rate of drug absorption and occasionally decreases the extent of absorption. Reducing the rate of absorption merely delays the onset of effect. Peak effects are not lowered. In contrast, reducing the extent of absorption reduces the intensity of peak responses. The interaction between calcium-containing foods and tetracycline antibiotics is a classic example of food-reducing drug absorption. Tetracycline bind with calcium to form an insoluble and non-absorbable complex. Hence, if tetracyclines are administered with milk products or calcium supplements, absorption is reduced and antibacterial effects may be lost. High fiber foods can reduce absorption of some drugs. For example, the absorption of digoxin used for cardiac disorders is reduced significantly by wheat bran, rolled oats, and sunflower seeds. This reduced absorption can result in therapeutic failure. Increased absorption. With some drugs, food increases the extent of absorption. When this occurs, peak effects are heightened. For example, a high caloric meal more than doubles the absorption of sequenafir or Inverase, a drug for HIV infections. If sequenafir is taken without food, absorption may be insufficient for antiviral activity. So, the effects of food on drug metabolism. The grapefruit juice effect. Grapefruit juice can inhibit the metabolism of certain drugs, thereby raising their blood level. Four compounds have been identified as the responsible agent: two furanocoumarins and two flavonoids. This effect is not seen with other citrus juices, including orange juice. Grapefruit juice raises drug levels mainly by inhibiting the CYP3A4 metabolism. CYP3A4 is an isoenzyme of cytochrome P450 found in the liver and the intestinal wall. Inhibition of the intestinal isoenzyme is much greater than the inhibition of the liver isoenzyme. By inhibiting that CYP3A4, grapefruit juice decreases the intestinal metabolism of many drugs, and thereby increases the amount of available for absorption. As a result, blood levels of these drugs rise, causing peak effects to be more intense. Because the inhibition of that CYP3A4 in the liver is minimal, grapefruit juice does not usually affect metabolism of drugs after they have been absorbed. Importantly, grapefruit juice has little or no effect on drugs administered intravenously. Why? Because with IV administration, intestinal metabolism isn't involved. Inhibition of that CYP3A4 is dose dependent. The more grapefruit juice the patient drinks, the greater the inhibition. So here's a list of some of the drugs whose levels can be increased by grapefruit juice. A good spot to hit pause just to kind of give yourself an idea of which drugs could be included. The inhibition of that CYP3A4 persists after grapefruit juice is consumed, so the problem cannot be easily resolved by scheduling medications hours after drinking the juice. In fact, when grapefruit juice is consumed on a regular basis, the inhibition persists up to 3 days after the last drink. The effect of grapefruit juice very considerable among patients because levels of CYP3A4 show great individual variation. In patients with very little CYP3A4, inhibition of grapefruit juice may be sufficient to stop metabolism completely. As a result, large increases in drug levels may occur. Conversely, in patients with an abundance of CYP3A4, metabolism may continue more or less normally, despite inhibition by grapefruit juice. The effects of grapefruit juice also vary considerably among CYP3A4 substrates. In one study, for instance, the co-administration of grapefruit juice produced a 406% increase in blood levels of calcium channel blocker phenoldiphidine. For some other drug metabolized by the isoenzyme, the effects are negligible. The clinical consequence of inhibition may be good or bad, as indicated by the following table, 4.3. By elevating levels of certain drugs, grapefruit juice can increase the risk for serious toxicity. On the other hand, by increasing levels of two drugs, the sequinavir and cyclosporin, grapefruit juice can intensify therapeutic effects by promoting a positive outcome. So, what should providers do if the drugs they are prescribing can be affected by grapefruit juice? Unless a predictable effect is known or desired, prudence dictates advising patients to simply avoid grapefruit juice entirely. So, the effects of food on drug toxicity. Drug-food interactions sometimes increase toxicity. The most dramatic example is the interaction between the monoamine oxidase, the MAO, inhibitors and foods rich in tyramine. So your aged cheeses, your yeast extracts, your Chianti wines. If a MAO inhibitor is combined with these foods, your blood pressure can rise to a life-threatening level. So, to avoid disaster, patients taking an MAO inhibitor must be warned about the consequences of consuming tyramine-rich foods and must be given a list of foods to strictly avoid. Other drug-food combinations that can increase toxicity can include the following. So, your theophylline, an asthma medicine, plus caffeine, which can result in an excessive CNS excitation. Your potassium-sparing diuretics, your aldactone plus salt substitutes, which can result in a dangerously high potassium level. Aluminum-containing antacids, your Maalox, plus your citrus beverages, so your orange juices, again, that grapefruit juice, which can result in excessive absorption of aluminum. So, effects of food on drug action, therefore. Although most drug-food interactions concern drug absorption or drug metabolism, food may also, though rarely, have an indirect or direct effect on drug action. For example, foods rich in vitamin K, your broccoli, Brussels sprouts, cabbage, can reduce the effects of warfarin, an anticoagulant. This occurs because warfarin inhibits vitamin K dependent clotting factors. And accordingly, when vitamin K is more abundant, warfarin is less able to inhibit the clotting factor, and therapeutic effects are in decline. The timing of drug administration with respect to meals. The administration of drugs at the appropriate time with respect to meals is an important part of drug therapy. As discussed, the absorption of some drugs can be significantly decreased by food, and hence these drugs should be administered on an empty stomach, or at least 1 to 2 hours before or after a meal. Conversely, the absorption of other drugs can be increased by food, and hence the drug should be administered with a meal. Many drugs cause stomach upset when taken without food. If food does not significantly reduce their absorption, then the drug should be administered with meals. However, if food does not reduce their absorption, then we have a difficult choice. We can administer them with food and thereby reduce stomach upset, but also reduce absorption. Or we can administer them without food and thereby improve absorption, but also increase stomach upset. Unfortunately, the correct choice is not obvious. The best solution, when possible, may be to select an alternative drug that doesn't provide the stomach upset. Drug supplement interactions. Dietary supplements create the potential for frequent and insignificant interactions with conventional drugs. Of greatest concern are interactions that reduce beneficial responses to conventional drugs and interactions that increase toxicity. These interactions occur through the same pharmacokinetic and pharmacodynamic mechanisms by which conventional drugs interact with each other. Unfortunately, reliable information about dietary supplements is largely lacking, including information on interaction with conventional agents. Interactions that have been well documented are discussed as appropriate through this text.